Dear colleagues, we're going to start relatively soon. We're just making sure everything is loaded up. This is a session on STI vaccines, and we're going to wait for some of the people coming out of the main hall. As we know that the current plenary was still going on. So please take your seats and get excited for STI vaccines. We'll be starting shortly. So can we ask the slides? While we're waiting, if you want to text your friends and say, come on over to Jacarandas, please do, because this is going to be a very brand new session. Rather than malaria vaccines, we're going to be talking about STI vaccines. And this was a session that was asked particularly of us from the SAA for WHO to pull together a group of experts to start talking about sexually transmitted diseases and what we're doing with infections. And post COVID, I think there's just such a great interest in how can we use all the new vaccine platforms to our benefit. So we hope without further ado, we can get the PowerPoints up and running. But we're going to have a session where we'll do a bit of a scene setting from myself, Meg Doherty, WHO headquarters. Then we'll move into a presentation from my colleague, Maya Vedemelo. And then after that, we'll have two presentations on where we are with vaccines development and all the science behind that from those who are going to be online. So are we ready to start? Slides? May I ask the team to put up the first slides, please? Okay, great. Who knew they put mute onto the microphones now? So thank you very much for joining. And I'm going to run through just a very brief introduction on STIs. Many of you may know this, but it may not be coming out as clearly in some of the presentations. But currently right now, our estimates are that we have 374 million new cases of the 4 treatable STIs, and those are syphilis, gonorrhea, chlamydia, and trichomoniasis every year. That translates into 1 million new STIs in young people, 15 to 49, every day. So in terms of burden, this is one of the highest burden infections that we are dealing with. And there is a great burden in the African region with approximately 96 million of these new cases in this region. Next slide. And we know that if we have STI vaccines, or if we effectively work to address STIs, we can reduce cancer from cervical cancers and other cancers. Go back, please. Go back to the previous slide, please. We can improve neonatal outcomes from congenital syphilis. We can decrease the burden of infertility. We can reduce HIV transmission. As we know, HSV or herpes can be associated with transmission. And we can support the health of young people and reduce burden of healthcare costs. Next slide, please. And we know the data are starting to show that we're having a rise in certainly syphilis and congenital syphilis, and data are showing as well a rise in gonorrhea. And for example, this year we had 3,000 reported new cases of congenital syphilis in the United States, all on top of having a shortage of benzathine penicillin, which is the current treatment. Next slide. So for us, we think this is an emergency. We also have seen multi-resistance gonorrhea emerging in different parts of the world, in particular in Southeast Asia. Next slide. And as you know, there are many challenges from being not funded, sort of under-recognized, no surveillance system that's available. And certainly there's a lot of stigma and discrimination and lack of vaccines. And we think this is an important thing to address. Next. Next slide, please. And so within our strategies for the last, let's say, 10 years, we've been looking at how we can address STIs by bringing it into our global health sector strategies for HIV, hepatitis, and STIs, noting that there's commonalities. And one of those commonalities is around innovation and vaccine development. Next slide, please. And so there's a roadmap that's been developed, and it also 2 sets of PCs, or preferred product characteristics. So there's work. It may be upstream, but it's now time to start taking this downstream, and that's what we're going to hear more about today. And next slide. And we just want to thank that there are a lot of people working on this. It's exciting. And we're going to have, for the next speaker, Maeve de Mello, who's going to give us an update from the perspective of WHO. Over to you, Maeve.
It's okay, you don't need to use it. If you can just project it, please. It's presentation number 4. All right. If I can control it from here. Where it's not showing. You can just do it from there. It's fine. So, okay, my task was to present on the development of vaccines for bacterial STIs, and will be followed by our colleague presenting on viral STIs, the vaccine development. Can I have the first slide for presentation 4, please? So we are going to actually start, no, it's hard without. Okay, so we would like, I want to start with, so we're going to approach syphilis, chlamydia, and gonorrhea in this presentation. So for syphilis, all the vaccines are still in the preclinical trial stage. That means it's still working with animal models. And so we do have a proof of concept. Oh, there we go. So can we move to slide number, if you keep going, please. Next. Yeah, okay, so this is a scenario that we have for for all the STI vaccine development. And what you have in red there is the bacterial ones we're dealing with, and the viral is what we're having the next session. So next one, please. So for syphilis, next, please. Okay, so as I said, syphilis are on preclinical stage. So next, please. So the proof of concept that it's possible to have a syphilis vaccine, is back from 1973. So clearly, considering the decades, it's a very tough task to develop a syphilis vaccine. So we have challenges because the Treponema pallidum, the bacteria, it's a very special bacteria and has, so it's a bacteria that can evade our immune system. The infection can persist for life. And this is due to the membrane, the outer membrane of this bacteria that keeps changing. So with that, it's very hard to actually develop a vaccine. But on top of that, there are problems with the models, the animal models, but also the young people are not really interested. So there's a shortage of researchers interested in STIs and not a lot of funding, although the scenario is changing a little bit. So next slide, please. So what are the possibilities in potential impact on syphilis vaccine? So if a syphilis vaccine becomes available, the theoretical impact based on mathematical models is promising. So with an 80% efficacious vaccine, with a vein protection of 5% per year over 20 years, it would be possible to reach elimination, even with a very low coverage vaccine. So similar results were also found using different background prevalences and using general population and also populations at higher risk. Next one, please. So that's chlamydia, and you can move to the next one again. You can move next and next. And next. Okay, for the chlamydia vaccines, they're a little bit more advanced. So we are in the preclinical stage, but also some studies in phase 1, moving towards phase 2. So next slide, please. So there's one study conducted in the UK, which has successfully, just remove this iPad here, sorry. Okay, so there's a study conducted in the UK that has completed phase 1, but it's pretty challenging to be implemented, although they are going to phase 2. So they got rich I can't say the word, immunogenicity using 3 injections, 2 nasal sprays in a period of 5 months. So that would be needed, which is really hard to implement. So, but there currently one study in the preclinical phase that's looking at a non-infectious species of chlamydia and a non-human infectious species, and with the potential of delivering that vaccine orally. So next slide, please. So model studies are more ambitious in this case. So what they've been showing is a 75% efficacy and immunity lasting for 10 years could decrease incidence, but is not a lot, as you can see in the graph. Next slide, please. So let's move to gonorrhea. In next slide. So there are 2 different approaches or different approaches to gonorrhea vaccines. So there are those candidates which are focused only on gonorrhea itself, and they use different targets, and they are all in the preclinical stage. But we also have the use of a meningococcal B vaccine that seems to offer cross protection against gonorrhea. So that's another way that the research is going, and using this outer membrane vesicle, both for gonococcal and for meningococcal. So let's focus on this more promising phase 2, phase 3 trials. Next one, please. So the enthusiasm started with this potential cross protection with programmatic data. And Cuba, which vaccinated kids for meningococcal B since the 70s, have shown, and it's just an association, right? So you see the graph in red and for gonorrhea, and the graph in blue for meningitis. And as they increase vaccination, you have a decrease in gonorrhea, and a further decrease when they started increasing the coverage of the vaccine. Same results were found published by Quebec and also Norway. Next slide, please. So then we had a little stronger study in New Zealand, which is a retrospective case control study with really large, where they vaccinated, looking at people which were vaccinated with meningococcal B vaccine, and they look at what was, compared with the control group, the matched control group, and also looking at chlamydia. And that was kind of a clear and significant decrease in gonorrhea infection. So the estimated effectiveness from this study was about 30%. Next slide, please. Next slide. Okay, so similarly, this is a very recent 2023 publication with a retrospective case control study in the US with a huge sample size, which evidence, again, of cross-protection. So the study compared individuals which had the MenB vaccine using the OMC, this is called the 4C MenB vaccine, with those who took another meningococcal vaccine that's a quadrivalent that protects against the types A, C, W, and Y of meningococcal. And what the results show is gonorrhea rates were 46% lower among those who took the MenB vaccine than those with the quadrivalent vaccine. And they control also for the incidence of chlamydia, and there was no difference found. Next slide, please. So, in summary so far, with all the observational case control and cohort studies, a MenB vaccine seems to have between 30 to 40% effectiveness against gonorrhea. Next slide, please. So with all those good news, we have currently 4 RCTs ongoing, some with results expected for next year, some a little bit longer. And let's not go over 2, it's too big. Next one, please. So what would be impact if you use this 30, 40% efficacy of the vaccines? So there is one study, so based on this efficacy, several mathematical models have been developed. And this one in particular, with the population of MSM, has shown that even with a limited efficacy of 50% could reduce gonorrhea prevalence by 62% within 2 years of only 30% of MSM were vaccinated when presenting to an STI testing. So they're really the higher risk MSM. So the similar results was found using with adolescent girls in England. Next slide, please. So UK, based on all this evidence, and even before waiting for the RCT trial results, the UK Joint Committee on Vaccine and Immunization advised now the use of the 4C MenB vaccine to prevent gonorrhea among those at great risks of infection. Next slide, please. So I think they're all good news, and I think there are also more good news regarding the funding. So we are seeing more and more funding towards development of vaccines, and also a raising awareness among the HIV civil society. Next slide, please, or next click on the slide. So, for example, I think you all know AVAC, long-standing NGO that fights for the development of HIV vaccine. They also embrace STIs. So they're tracking the progress and really trying to get civil society engaged. And they have a special website for that. So next slide, please. So with that, I thank you several colleagues, but I want to make a special thank to my mentor, Sammy Gottlieb, who has been teaching me for years now about, she's really our champion on vaccines, and she's been teaching me for the next few years. So, no, and we'll continue probably. Thank you very much.
Thank you. And I think now we're going to, noting that we started a little late, we have 2 more presentations to get through, and we want to have some Q&A. So please hold on to your questions. We're going to move right into the presentation on viral vaccines from Sinead Delaney Worthy. And can we have the slides on viral vaccines brought up? And she should be, Sinead, are you linked in? And can you show us yourself? Let's see if she's linked in. She's not linked in. Okay. So there is a video. So if we can move to her video, I think that would be the best way to do it. While we're waiting, is her video loading up, team in the back? Okay. Excellent. So we'll pass on to Sinead, who is going to give you an overview. Please start the video.
Thank you so much to the conference organizers for giving me the opportunity to give you an update on the
while we're waiting for the video to start.
Viral STI vaccines. I'm sorry that I cannot be with you at the conference, and I hope it's going well.
Burning question.
So as you know, there's a strong case for the development of vaccines really to improve our efforts.
The first was to optimize development.
And about a decade ago, WHO and the National Institutes.
Thank you so much to the conference organizers for giving me the opportunity to give you an update on the development of viral STI vaccines. I'm sorry that I cannot be with you at the conference, and I hope it's going well.
Investment in STI vaccine
so as you know, there's a strong case for the development of vaccines really to improve our efforts at STI prevention and control.
The second was to expedite
and about a decade ago, WHO and the National Institutes for Health articulated a roadmap to stimulate STI vaccine development. It prioritized 3 work streams. The first was to optimize optimize investment in STI vaccine development.
So I always like to remind
by better
myself
articulating the public health value of these vaccines.
The
second was to expedite research and development. And the third has been to optimize delivery by defining early on in the product development pathway the preferred product characteristics of a vaccine that would be used in low and middle income countries.
And it's wonderful to fast forward.
So I always like to remind myself about this quote or these remarks from a 1989 article, which was addressing whether or not we could successfully develop an HPV vaccine. And what you can see is that the authors really didn't believe it was possible, and they had serious concerns about study design and also whether these vaccines would be acceptable. And it's wonderful to fast forward to the present day and to see HPV vaccine introduction in many countries, including in the African region.
Very tolerable and has
HPV vaccines really are the poster child for vaccines that can be developed for viral STIs. We have a highly effective vaccine that's over 90% effective in preventing both HPV infection, but also precancerous lesions and anogenital lesions, and has very tolerable and has an excellent safety profile. What we've seen since the introduction of these vaccines in 2006 is impact at a population level on HPV-16 prevalence, but also impacts on lesions. And in recent years, we've seen a number of countries reporting actually declines in cervical cancer incidence following introduction of this vaccine. And this has really prompted a focus on the strategy to eliminate cervical cancer through the intensification of a number of strategies, including vaccination. And the 90-70-90 targets were really based on this modeling exercise, which showed that with vaccination alone, we could avert more than 45 million deaths. And that if this was combined with intensive screening, we could have even greater gains, such that if the 2030 targets were met and sustained, we could avert as many as 65 million deaths. So what has this meant really for progress on HPV introduction globally, but particularly in low and middle income countries, and particularly in Africa, where we have a high cervical cancer burden? So 136 countries have actually introduced HPV vaccine, but only 5% have achieved the 90% vaccine coverage. And there are a number of reasons for this. Approximately 1 in 5 girls globally have received the first dose, and that's about 1 in 3 HIV in Africa. And this really reflects the challenges of delivering this program to a population which is not the traditional EPI population. In addition, there have been a number of challenges that have delayed introduction, particularly in the African region, and that includes cost, and not just the cost of the vaccine, but also the cost of the delivery, largely as part of a schools-based program. And this is coupled with the fact that this delivery is in fact complex because it involves 2 doses, 2 campaigns, and the fact that it's a unique population. And there is much more work to do really to achieve the coverage levels that we've set ourselves. It's partly because of this that there's been discussion about whether we can simplify the HPV vaccine regimen, and following strong evidence that came from multiple studies, both observational and randomized controlled trials, WHO SAGE recommended a 1-dose schedule for HPV vaccination in girls aged 9 to 14. One of the caveats of this recommendation is really that we don't have strong evidence about the efficacy of this approach in people living with HIV. Countries like South Africa, where we have a higher burden of HIV. But clearly there are critical questions that remain about vaccination for people living with HIV. We have some reassurance in South Africa, and this is data from the HOPE study, which looked at the population impact of a single-dose vaccination on HPV 16 and 18 by HIV status, and we saw no difference between people living with HIV and without HIV, but this is a population that was well controlled on antiretroviral therapy, and we clearly need more evidence. So one of the things that people have considered is, can we potentially enhance our intensive screening approaches through the development of therapeutic vaccines? And this is because we know there are challenges with the scaling up of current screening approaches. And modeling suggests that therapeutic HPV vaccines could potentially accelerate and overcome some of the barriers we have to traditional screening. There are no licensed product as yet for therapeutic vaccines, but there are a number of candidate vaccines based on a wide variety of approaches. And a recent systematic review found that there is modest but significant efficacy in, 1, the regression of precancerous lesions, but 2, viral clearance. And it does appear that viral clearance is probably more technically feasible than regression of lesions. And this has really prompted WHO to undertake a consultation around the preferred product characteristics for a therapeutic HPV vaccine, and we're likely to see this endorsed in the coming months. What about the potential for an HSV vaccine? Well, really, there's clearly a case for it. We have 500 million people living with HSV2. The costs associated with HSV2 for low and middle income countries amount to $800 million US, and 1/3 of new HIV infections are attributable to HSV2. So in fact, one of the first PPCs that WHO developed for STI vaccines was the HSV PPC, and that looked at options for both a prophylactic and a therapeutic vaccine. What the field has seen is that prophylactic vaccines have been challenging to develop, but there has been renewed interest in the development of therapeutic vaccines, particularly now that we have a more widespread use of the mRNA platform. And in fact, there are 2 trials that are currently recruiting, one led by BioNTech and one led by Moderna, that are both looking at evaluating HSV therapeutic vaccines in early studies. One of the questions is, would a therapeutic vaccine have any population impact? And here was some modeling done based on a South African population, which suggested that a highly efficacious therapeutic vaccine that had lifetime protection, but as little as 40% coverage, could reduce HSV2 infection by about 30%, and similarly could also have an impact on HIV infection. So this is promising data, and we look forward to future results. It's probably important to recognize that we've seen emerging STI threats in the last decade. Ebola initially, and more recently the Mpox outbreak. And while we've seen declines in Mpox cases in the US and Europe, there is now an ongoing outbreak in the Democratic Republic of Congo, which appears to be associated with sexual transmission. Early on in the Mpox outbreak in 2022, WHO made recommendations around vaccine use, and this was based on the recommendations for vaccines against smallpox. And many countries in high-income countries actually implemented these recommendations. What we've seen from a CDC report in the US is that about a third coverage of the first dose, and it's likely that declines in Mpox were due to a combination of factors and not vaccines alone, but in vaccines are an important part of an outbreak control strategy. Unfortunately, when we look at the situation in Africa, we really have limited access to vaccines for Mpox despite the outbreak, and this is really highlighted in this article at the bottom of the slide, which really makes the case for now why we need to develop vaccine development and manufacturing capacity on the African continent. So I think there are a number of important lessons learned that are worth reflecting on. The first is that we've made important advances both in basic science but also vaccine technology, which make STI vaccines feasible. Even if you have highly effective vaccines, you need to kind of pay attention to delivery strategies and cost so that real potential can be achieved. And the PPC process offers an opportunity to define the characteristics of vaccines that could be used in low and middle income country settings where delivery, cold chain, etc. are important considerations. And if we want to stimulate development of vaccines, we really need to articulate the full value of these vaccines, particularly for neglected diseases like STIs. And ultimately, we need to build capacity on the continent to develop these vaccines. What did COVID teach us? Well, with a sense of global urgency, we can overcome huge obstacles. Scientific collaboration is critical to success. It's possible to reduce the timelines for development with significant investment. There will still be barriers to uptake if we don't address the important considerations around vaccine confidence. And again, if we don't build manufacturing capacity on the continent, we will be left behind. So in conclusion, there's a clear need for the development of STI vaccines. We have an important prototype in the HPV vaccine. We recognize that vaccine development might be a risky process, but it is helped by articulating the preferred product characteristics and the full value of vaccines in settings like in the African region where we have a high burden of STIs. We've seen important advancements in recent years in the development of vaccines for viral pathogens, and we've learned some important lessons recently about what we need to do to ensure access. But ultimately, we do need to build capacity for the development of vaccines on the African continent if we're going to achieve our goals of preventing and controlling viral STIs. I'd like to acknowledge these people and thank you very much for your attention.
Okay, thank you. We're going to go on to our third presentation, which is going to be done, I think, virtually as well with a video, which will be a presentation that I think will be intriguing to all of you because of COVID. There has been a real push for tech transfer, and here will be a discussion around the mRNA vaccine being developed for gonorrhea for tech transfer. So Petro Terblanche will be making the presentation.
Good morning. Thank you for the opportunity to present the early work that the mRNA technology transfer program is starting to looking at gonorrhea vaccine, mRNA gonorrhea vaccine. I'm sharing my slides here with. So this presentation will give some background on the WHO and Medicines Patent Pool Technology Transfer Program, but particularly focus on the early work on the development of the mRNA vaccine against gonorrhea. The history of the program in 2021, announced by Dr. Tedros and leadership to start a program within a period of 12 months to build a network of partners and an mRNA technology development hub with a consortium in South Africa to address critical issues around vaccine equality and access to mRNA vaccines for low and middle income countries. Why mRNA? Very important to realize and notice that this program is focusing on giving access to mRNA technology for low and middle income countries. mRNA has demonstrated its suitability for making vaccine capabilities accessible to low and middle income countries. The small footprint and some of the specific modalities and multi-product orientation of mRNA platforms makes it very attractive for low and middle income countries to invest and to acquire this kind of technology, and certainly led by Medicines Patent Pool and World Health Organization to make these kind of platforms accessible. This just demonstrated the multifactorial and multifunctional abilities for mRNA as a therapeutic, a vaccine, applications for veterinary health, but also for crop protection. What this program is about is in Cape Town, in South Africa, to build a platform for mRNA vaccine development, a COVID-19 vaccine being used as the backbone to validate the platform, and very early on already innovation on the platform to look at issues around cost of goods, thermostability, freedom to operate, and to ensure that an mRNA platform which is developed in South Africa and transferred to the 15 partners in this program are suitable for future vaccine manufacturing and innovation. The program very early on also focused on innovation to ensure that mRNA is suitable for public health applications. And the key areas of innovation is around manufacturing technology, with the collaborations that we have with partners looking at reducing cost of goods, formulation technology to address issues around thermostability and improve vaccine quality, and very important for this presentation, assessment of additional targets, looking at unmet needs in low and middle income countries and where mRNA is suitable as a platform for manufacturing of these vaccines. Again, building an ecosystem around mRNA manufacturing, both the IVT reaction and the LNP manufacturing, to foster capability for mRNA manufacturing in low and middle income countries, but also innovation around specific drug targets and pathogen targets for mRNA. So currently the program has identified priorities, the ones in red here, of which HIV and gonorrhea are also very relevant for this particular session from WHO in the satellite event at ICASA, starting the development work of mRNA vaccines for the network, for sustainability, but also to address public health needs. So in the assessment of the potential priority vaccines to develop by the program, we very closely work with WHO and recognize the importance of understanding the probability of technical and regulatory success and the probability of policy development procurement. And just note here, gonorrhea here marked as not as a green, not an easy probability of technical and regulatory success, and also not in the policy environment. So really conscious of the challenges around developing a gonorrhea vaccine, we have entered into this program with a strong partnership. So background about gonorrhea, the surging and the burden of disease, the multi-drug resistance challenges, the increase of the risk in HIV infection, particularly relevant for Southern Africa. This has been discussed earlier by Meg and also by Maeve in this program. I'm going not to repeat this. I think there is sufficient background motivation why gonorrhea is a very important intervention to be targeted. And again, I think earlier also the discussions on the current status of vaccines, the great work that's been done by Pfizer and GSK with the serendipity finding of the meningitis B vaccine and its efficacy in gonorrhea cases, and the fast track GSK receiving US FDA fast track designation for investigational vaccine against gonorrhea. So why is the mRNA program involved, and what are we focusing on? So this is a partnership program realizing the difficult target that mRNA, that a gonorrhea vaccine will present, but also looking at the potential and the possibilities for mRNA to make a contribution to develop of a vaccine that will be accessible and be ability for low and middle income countries to produce. So we have a partnership here with Evaxion, which is an AI platform, innovative platform. They've identified 26 different candidates for a gonorrhea vaccine. Again, here these proteins has been tested in early animal studies in a different platform. And presented some possibility for vaccine development. This Evaxion B2 protein has now already been demonstrated to be highly immunogenic in mice and elicit bacterial antibodies against most of the 15 human clinically relevant strains for gonorrhea, and the preclinical model has been validated. Afrigen and Evaxion is developing a plan, and we have started early designs of the mRNA construct, which encodes for these lead proteins being identified in early preclinical data to show immunogenicity and also to elicit the the bacterial antibody responses. We together are now with Evaxion are working to test multiple RNA formulations in a mouse model for immunogenicity and protection. The intention is to proceed as fast as possible to clinical development. And here again, I want to recognize the support and efforts from Charles Gore and the MPP team to provide early seed funding through the Canadian government for us to do work on this novel mRNA vaccine against gonorrhea. Maybe as a summary, Afrigen has established a consortium of partners to look at addressing a high burden, very important multi-drug resistant disease and to develop a prophylactic vaccine against gonorrhea. We're building a platform based on COVID-19, but the platform is being designed to be multi-purpose and multi-product. Particularly are we looking at the possibilities of utilizing this platform not only for respiratory viral pathogens, but also for bacterial pathogens such as gonorrhea, but also for parasites to ensure the application of this platform for multi-applications. mRNA technology will continue to significantly contribute to public health, and we're looking forward to working with our partners in the mRNA program in the 15 countries, 15 companies to jointly develop vaccines that is of relevance for the burden of disease in our areas as a quest for sustainability, but also pandemic response. We fully recognize that manufacturing alone is not sufficient for sustainability, and therefore we're working in partnerships to optimize the platforms, but also to develop new programs. And again, to emphasize, partnerships will be the key success for us in this program. Just a final slide to thank you, World Health Organization, Medicines Patent Pool, the funders, the collaborators across the globe, our 15 partners in building a platform for sustainability, for innovation, but also for pandemic response, pandemic preparedness. Thank you very much.
Thank you. Please, let's give a better applause to all our presenters.
Thank you.
Our time is fast spent, but we can take 2-3 questions. And for avoidance of doubt, this session is about envisioning the future. Building capacity for vaccine development in Africa is a big deal. Ensuring that the science is comprehensive, whether it is bacterial STIs or viral STIs, that means expanding the capacity in such a way that when the next pandemic hits, Africa will be ready. Please, go ahead.
Thank you so much for the wonderful presentation from all 3 speakers. My name is Cham from the University of Botswana, medical student and a passionate sexual reproductive health peer educator. So I have just two questions. That being a recombinant in mRNA vaccines, which we know are highly specific, will these vaccines, especially those for the bacterial STIs, be administered as a combination vaccine like the MMR vaccine, or will each STI have its own vaccine? And the second one is that since they're being administered to people who are most likely sexually active, will they be given like HPV to girls who are, say, in grade 5 and 6, as Zimbabwe does, or will they be given as an influenza vaccine to people who are especially sexually active? So to speak that I will go and ask for the vaccine myself, or it's just going to be a program that's going to be run depending on age. Thank you.
Thank you. Any other? Is there a third question this side? Go ahead, please.
Okay, thanks to the presenter, and this is a good development, especially in our region. But the concern I have is looking at the effort at the country level. This platform that we are talking about, is it open for country or is just group of firm? Why I'm asking is, you know, if we are looking at sustainability as it was well captured there, if countries are not probably engaged at this stage and we get to probably a stage of formation and we are introducing, then it might probably be a setback for us. So countries like Nigeria, where I come from, we have the will, and then the partners like WHO in country and other donors are currently making move on how we can start some vaccine production. Now that this is coming, I think it will be good if we can identify isolated countries like that and then we synergize. Thank you.
Thank you. Go ahead.
Yeah, so really exciting work. My name is Wale from WHO. The burden on young people is quite huge, like you rightly mentioned at the start. The question is about considerations for young people. Are there any particular specific considerations for young people as you take this really exciting work forward? Thanks.
Yes, next you can go quickly.
Yes, thank you. Thank you, the presenters. Wayne Otieno from Kenya, Catholic Medical Mission Board. Yeah, so my question, I think the other question has been asked. I had two, but one is about the vaccine access. If we get to roll out, I know you all remember what happened during the COVID-19 vaccination, where access to vaccination was still a challenge to most countries. And even the HPV vaccination is still low, suboptimal to most countries because of access. So even as we develop new vaccines, are we going to sort out the issues of access? Thank you.
Thank you. And finally, at the back there.
Je peux. Excusez-moi, je parlais en français. C'est Mohamed Yousfi, infectiologue, président de la Société algérienne d'infectiologie. Merci pour les 3 oratrices. Merci pour les efforts que fait l'OMS. Ça vient d'être dit par mon prédécesseur. Toute la problématique de l'accessibilité dans les pays en voie de développement pour les vaccins. Et le meilleur exemple, c'est ce qu'on a connu au cours de la pandémie Covid. Qu'est-ce que prévoit l'OMS pour cette accessibilité? C'est bien qu'il y ait déjà un pôle au niveau de l'Afrique du Sud pour la fabrication de ce vaccin, mais qu'est-ce que prévoit l'OMS pour pouvoir affronter cette problématique de l'accessibilité au vaccin d'une manière générale et dans les STI d'une manière particulière? Merci.
Yes, you were saying that is from Algeria. And the main question was just like his predecessor, he was asking about what is the WHO doing on for us to have access to these vaccines. So that was the main question. Thank you.
May I? Okay, it's quite a lot of questions, but I think what we really try to present here is the work regarding the development of the vaccines, but there's also the implementation phase. So what we do create with those documents in terms of the preferred product characteristics for each vaccine is exactly to start thinking ahead of time to who is going to be the target populations, we're going to have, in how to implement it. So countries don't wait for the vaccine to be released, to be approved, until then start moving. So we're trying to accelerate the process that has happened with HPV, that is still taking a long time, and starting to prepare countries ahead of time with those kinds of documents. Of course, this has to trickle down, but I think there's an enormous amount of questions regarding implementation. And I think that would take another 45 minutes because there's so many barriers regarding how to do. But I think there's a lot that the country can do itself. And I think we're, Afrigen is here, and we're really proud that you guys are working on this.
So I'm not Afrigen, I'm the Medicines Patent Pool, and as you saw in Petro's presentation, we're working really, really closely with Afrigen for this. So first up is your question to Nigeria. Nigeria is a program partner. So what does that mean? We are working really closely with Nigeria and BioVaccines to bring them up to speed. So they have already gone down to Afrigen and had the first technology transfer training. The idea, of course, with these 15 program partners is they are set up in all low middle-income countries and are able to do the R&D, first of all, using the mRNA technology, develop some of the vaccines that you saw, or do the R&D on the vaccines that you saw that were presented in Petro's slide. And once they have come through with that breakthrough, that they transfer what they have learned back to the other 15 program partners so that they can then take it to scale as well and start and make those vaccines better. With regards to the mRNA, at the moment we're doing monovalent, but in time the idea is to do polyvalent. And so what this whole mRNA program is about empowerment. It's about empowering low middle income countries to work on R&D, to develop the vaccines and make them available in low middle income countries for low middle income countries. After that, if the North would like them, then they will find a way to charge them for them. So that's the idea. It's a way back that way. So we're here to share. We're here to make it go further.